Today on Cancer Buzz, what it's like to be the only medical oncologist deep in a rural community.
And I have wonderful patients. They value you as a doctor. You are very much a part of the community. And I get to be an oncologist and a physician in the fullest way possible, practicing here in a rural area, very much on my own. I get to be a physician in the fullest way possible. So I would encourage any resident to really think about coming back to a rural area to practice. It's a special joy.
Welcome to Cancer Buzz. I'm your host, Summer Johnson. Thanks for joining us for the final episode in our three-part series on rural cancer care, which was brought to you in collaboration with the Montana State Oncology Society. Today, we're talking to one provider who's intimately familiar with the challenges and opportunities of being the only medical oncologist in a remote community. Providing care to patients with cancer in rural areas isn't easy. There are a host of struggles unique to living and working in remote areas that providers and their patients deal with every day, including weather and travel distances, insurance obstacles, poor health habits, a lack of access to clinical trials, and fewer specialists, such as radiation and medical oncologists. All these factors can lead to worse outcomes for rural patients with cancer. Quality care delivery is even more difficult without access to the resources of a larger cancer center. Being the only medical oncologist for an entire town and its surrounding area isn't for the faint of heart. And as we discovered, it takes a healthy sense of humor. You heard that right. Our guest today, Dr. Chad Pedersen, is the very busy and sole medical oncologist at the Sidney Health Center in Sidney, Montana. About a 4-hour drive from Billings, the town of Sidney is situated in the Yellowstone River Valley of eastern Montana. Sidney is home to about 6,000 residents, but Dr. Pedersen has the charge of treating cancer patients in the greater Richland County around Sidney, with a population of about 100,000 people. The Sidney Health Center staff, along with Dr. Pedersen and a radiation oncologist, provides chemotherapy, IV therapy, and radiation therapy in one location, something that's very rare in rural care. He also believes that patient-centered care with a focus on prevention and early detection is key to community health. We spoke with Dr. Pedersen about why he returned to his hometown after his training, the pressure of being his town's only medical oncologist, and what that means for him, his patients, and their care.
I grew up in Sidney, Montana, which is a small town in eastern Montana, right on the border of North Dakota. It's a very rural place, farming community. More recently, a lot of oil activity. It's in the Bakken Formation that is in western North Dakota and eastern Montana. And I went to medical school at University of North Dakota in Grand Forks, North Dakota, which I think provided excellent training for what I'm doing now. I always wanted to come back to Montana and practice rural medicine, and University of North Dakota really prepared me well for that. And I did all of my postgraduate training at a healthcare system called Gunderson, which is centered in La Crosse, Wisconsin. It's a big, small health system in western North Dakota that serves the tri-state area there. And so I did internal medicine as a chief resident and did my fellowship in hematology and medical oncology at Gunderson. I received really excellent training because, now I'm practicing without the benefit of partners or a big group practice in a very rural and very isolated place. So I'm very thankful for all the training I had and the mentors I had along the way.
What led you back home?
Yeah, that's was something I hadn't necessarily planned on. When I was in medical school and training, there was not a cancer center in my hometown, and patients had to travel elsewhere. But while I was going through training, they built a cancer center, including radiation treatment, because otherwise Sidney is so rural and isolated that patients would have to move somewhere else to get radiation treatment. It's hundreds of miles away from the next closest radiation treatment facility. So they built this radiation treatment facility and also a small infusion center, and that happened while I was going through training. And when I was considering my options after training, home and I took a tour, and I got really excited about the opportunities because there was not a medical oncologist in the cancer center. It had been served by outreach services that would be present one day a week or one day every other week. And they had never thought it possible to recruit a medical oncologist. They'd given up on the possibility, but it just so happened that this was home for me, and I got really excited about the opportunity and what could become of this small cancer center on the northern plains.
Paint a picture of us, if you will, of your day as the only medical oncologist at Sidney Health Center. I have to confess, I'm picturing Doc Hollywood here, if you ever saw that Michael J. Fox movie. Do you have a tiny red car?
Yes. Yeah, every day is full of surprises, for sure. So every day is very, very full. It's long days. I'll just work long days, but, I love what I do. So, we have patients that will travel sometimes, from 2 hours away. We have a very large catchment area because I'm the only full-time medical oncologist in eastern Montana. And so I see patients from far and wide. We see all different types of cancers, including rare cancers. Surprised at how many rare cancers I see. And so all different types. I'm very much a generalist, and including hematologic malignancies and benign heme. We try and take care of the community. So, I have been in a situation where, patients not going to go anywhere else. I want them to go to a bigger center, and they're just not going to go. And so I do my best to take care of whatever comes through the door. And that definitely stretches my medical knowledge and oncology knowledge, but I love it. I really love it. And so I try and see patients in the hospital. I do bone marrow biopsies, more bone marrow biopsies than anyone else in a very big area. We try to provide a home for patients that have undergone transplant and need a local home when they're going back and forth or returning after transplant. And I see patients from all different walks of life. This is a rural area, so my patients are wonderful. They really respect doctors, but there's a lot of poverty. There's drug use, which is rampant in rural areas, but all across the country, of course, but hit rural areas hard. You have large Native American population. And so my days are very full, and all different types of cancers and all different types of patients, lots of different backgrounds.
How many people are you treating for cancer in a town of 6,000? And then you said that there are more from the county and other areas that come to you.
Yeah, so it's amazing. I see, 1 or 2 new patients a day. We have, about 60 patients on active treatment, which for me, that's a lot to keep track of, especially since care is very fragmented. So patients are coming from great distances. There are multiple independent hospitals in the region. There is not one unifying healthcare system. So patients end up getting care in lots of different systems, records in lots of different systems, labs and imaging in lots of different systems. And to try and keep track of all of that presents a special challenge. That's one of the big challenges I have. But we were a busy, small cancer center because it's a town of 6,000, but we serve a much larger area, approximately a population of about 100,000.
What about your staff? How many do you have, and do you have any problems recruiting or retention?
Oh, yes. It's incredibly difficult to recruit. So I am lucky. I have wonderful nurses, wonderful pharmacists. We have a great staff of infusion nurses, but it is incredibly difficult to recruit. So we've been trying to hire nurses. We've been trying to hire nurse practitioner or PA, and there are not extra nurses around. They're working here at the hospital, and there's nowhere else to pull. There's not a nursing school nearby, so that makes it harder to recruit. And we're very rural and isolated, and so it's hard to get recruits here. And if they've traveled here, they realize just how rural and isolated it is, and they're not quite what they expected. I know there's a shortage of healthcare workers everywhere, but in a rural setting, it's especially difficult and acute. There's a real brain drain where young people grow up here, they leave, and they don't come back. So it's really hard to get the educated healthcare workers to come back, and that's an ongoing challenge.
We talked about some of the rare cancers you see. What do you think are the biggest opportunities or threats to providing quality care for your patients?
We can treat most patients with most cancers, but there are two challenges that I face on a daily basis that make it a lot harder as an oncologist. And one is the fragmentation of care. So, for instance, I'll have a woman who I'm seeing who's recently diagnosed with breast cancer. It's entirely possible that she had her mammogram at one facility, went to another facility and had a biopsy. That pathology goes outside the facility to a different pathology group. She's referred to a surgeon after a diagnosis is made. That surgeon may be with a different institution, will undergo surgery and have pathology done in a different institution than where the original biopsy was done. May have reconstructive surgery by a different surgeon with a different group, because plastic surgeons are separate. And we'll see me in yet a different institution here at Sidney Health Center, and the primary care provider may be totally separate, unaffiliated with any of these aforementioned groups. And so trying to piece together the story and to get all the pathology, all the imaging, all the records is a huge challenge, and I think a real opportunity for growth. If we had better interoperability of electronic medical record systems, that would help a lot to this challenge of fragmentation. So that's one of the biggest challenges I deal with, and trying to coordinate with these different institutions for follow-up care. Then the second major issue I face is in a cancer center, there's usually a lot of supportive infrastructure with other specialists. So I don't have the benefit of a readily accessible pulmonologist or infectious disease doctor or any of the other many specialists that help part of the care team in taking care of cancer patients. And it's really hard to get patients to these specialists from this area. So in that way, I'm stretched because I'm sometimes trying to be the pulmonologist. I'm trying to be the infectious disease doctor. And going back to what I said about the great training I received, I'm so thankful for the great training I received to be able to come back and serve this area when I don't have ready access to other specialists.
Finally, what would you say to residents who are thinking about entering oncology, about the need and the value and the benefit of going to work in a small town?
I knew it would be rewarding coming back home, but it is more than I ever imagined. Since I grew up here, I every day see patients who I knew growing up, or they know my parents, or they knew my grandparents. But that's a special joy. When you're practicing in a small area, the community values what you do. They want to keep you. And my patients are wonderful. One of the things I worried about coming back and being the only medical oncologist was, how am I going to be on call every single hour of every single day? Because when I was on call and training, you get patients calling all throughout the day and all throughout the night. And I wasn't sure how I was going to manage that. Well, what I learned was that patients don't call the doctor. The patients here, they're very independent, and they don't want to go to the doctor unless they don't have to, and they're not used to being able to call the doctor, and so they don't call. They find a way. They're used to making it on their own. And I have wonderful patients. They value you as a doctor. You are very much a part of the community. And I get to be an oncologist and a physician in the fullest way possible, practicing here in a rural area, very much on my own, but I get to be a physician in the fullest way possible. So I would encourage any resident to really think about coming back to a rural area to practice. It's a special joy.
Thank you to Dr. Pedersen for that peek into your work. We know you're a busy cancer care professional, and we want to thank you for spending your free time with us. If you like what you hear, and we hope you do, please leave us a review. You can also share this episode with your colleagues. That's how we grow our audience and we create more content for you. In the new year, we have a full slate of shows with fresh insights and perspectives on the latest developments in cancer care. Make sure to hit the subscribe button so new episodes are delivered straight to your device. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.